Hi, this is Sakib Rahman from the OrthoClips Podcast Series, and today I'm with Surena Namdari. He is Associate Professor of Orthopedic Surgery, Fellowship Director, and Co-Director of Shoulder and Elbow Research at the Rothman Institute in Philadelphia and Thomas Jefferson University Hospitals. Welcome back, Surena.
Thanks so much for having me. It's great to be back.
Great. So today we're going to be talking about geriatric proximal humerus fractures, what to do. And as a matter of fact, this is similar to a topic we're going to be talking about next Saturday, June 12th, at the online Philadelphia Orthopedic Trauma Symposium webinar. So if anyone's interested in hearing more about this, you can go to orthoclips.com and follow the links for this year's meeting. But let's get into it, Dr. Namdari. So I guess one of the first questions I had was, how do you define geriatric when you think about proximal humerus fractures, and why does that matter? How does it affect your decision making?
Yeah, I think that's a really good question. Before I answer it, I think the another plug for the upcoming meeting. I think discussing topics like this in a group setting with high quality experts that will be on the panel is so important, because these problems you can treat in so many different ways. And so we look at the x-ray, and it may be the same x-ray but attached to 5 different people, and you may treat it 5 different ways. So I think it's so important to kind of talk about our indications. But I think your question's a good one, because it starts off with the idea of what is geriatric, and I don't think there's a definition of geriatric. So, I think geriatric is what you perceive it to be in a lot of ways. And so we know that chronologic age is not necessarily the same as physiologic age. So, there are plenty of patients who are 70 plus who are healthier than other patients who are in their 40s and 50s. Similarly, there are patients in their 70s who may have better bone quality than somebody in their 40s or 50s with other medical problems like inflammatory arthropathy. So, but I think generally speaking, if we're going to give it a number, geriatric is commonly thought of to be somewhere greater than age 65. I think that is certainly shifting, and it's becoming older and older. But I think that that's sort of where we consider it to be. And that's usually because patients who are at that level or older may have some attritional bone loss. They may have some other medical comorbidities that may complicate their decision-making in terms of both surgical and non-surgical treatment. And then sometimes patients in that older age category have other assistive needs. They may or may not live independently, or, they may need their arm function in order to live independently. So I think all of that plays into the decision-making.
Right. I guess if I want to think of not exactly a corollary, but let's just pick another fracture. Intertrochanteric fracture. Person comes in with an intertrochanteric fracture. Sure, there are a lot of maybe demands that may vary between one patient and the other, and their occupation, their needs, bone quality, et cetera. But I would say my treatment is not that much different if it's a 35-year-old versus if it's an 85-year-old. But would you say in the proximal humerus that this really plays a role in your thought process? I think it does, but how much when you see one of these patients that you're weighing their age in your decision making?
Yeah, I think it definitely is different, like you said. Like you pointed out, hip fractures, we fix them. Proximal humerus fractures, you can make an argument to treat them all potentially, or almost all of them, non-surgically. And so you really have to tease out which patients you think are going to benefit from surgical treatment and which ones are okay to treat non-surgically. And age definitely plays a part in the equation, because it's a surrogate for other issues. And so I think that my partner Jim Krieg calls a lot of his older patients with these injuries functional quadrupeds, because even though we don't walk on our arms, a lot of these patients, they use their arms to get up from a seated position, to transfer, they may have low back pain, they may have weakness or deconditioning of their legs. And so they do require or rely on their upper extremities in order to get around. And so for that patient, you can make a strong argument to fix some of these because they may need it in order to get around in their day-to-day.
Okay, good points. Let's talk about criteria. What would you say are your criteria to treat geriatric proximal humerus fractures operatively? And how much does your criteria, derive from experience versus evidence in the literature?
Yeah, I think the literature is somewhat confusing. I think that, if you look at the most popular trial, the Proford trial, which was in JAMA a few years ago, and then subsequently follow-up studies have been published. But they showed essentially no difference when you treat these fractures surgically or non-surgically. But I think many of us who treat these injuries understand that there were some limitations in that trial that may not make it applicable to the patients that we see on a day-to-day basis. They excluded ones that they considered obviously in need of surgery. So, I think that there are some injuries that we look at and we understand need to be addressed. And so whether that's your fracture dislocation, whether it's a shaft that's very medialized and, near the glenoid or even medial to the glenoid, whether it's a varus displaced four-part fracture where there's no contact between the head and the shaft segment. I mean, I think there are some fractures that you look at and you understand that the literature excluded those fractures when they did randomized trials. So, I mean, there are certainly ones that I look at and I think to myself, this patient, if I fix this fracture or if I replace this joint, they're going to do better from a functional standpoint. And I can't say it's purely from the literature. It's more gestalt and experience at this point. But I think that on the flip side, there's certainly really horrific looking x-rays that I treat non-surgically because the person they're attached to, I do not think will do well surgically, either from a medical standpoint, a social standpoint, or simply I don't think the bone quality is good enough to support fixation or sometimes even replacement. And so, I have plenty of patients who have bad looking x-rays who have healed or maybe have gone on to not heal that I still, looking back on, would still treat them non-surgically.
Yeah. I mean, speaking about some of those patients, I was wondering that, ugly x-rays happen. We get these malunions sometimes in lower demand patients where we accept that. Is that tolerated better functionally than, and we'll use the proximal femur for an example again, than in the proximal femur, meaning like if we were to treat a proximal femur fracture non-surgically and they end up with varus malunion and shortening, et cetera, it seems to me like those are tolerated much more poorly than in the proximal humerus where you get a really ugly x-ray. Is that true? Or are all my malunions coming to your office and I just don't realize what's really going on?
They're definitely not coming to my office. I think, your point's a great one. I think that, it is definitely better tolerated. I think there are a few reasons for that. I think one is that, when the bone heals, for the most part, pain is either eliminated or at least vastly improved. And so for most patients who are in that geriatric or older population, if they don't hurt, they're fairly content with what they have. And so then when it comes to function, we have the benefit in the shoulder of scapulothoracic motion. So I think that even though the shoulder can get stiff, the glenohumeral joint can get stiff, or a malunion can lead to bony contact between the tuberosity and the acromion and limit glenohumeral motion, we can compensate with scapulothoracic motion. And so most patients, even with a bad non-union, can still get their arm to about chest height, can still get to their head by bending their elbow, and still have some level of rotation. And for most daily tasks, especially if they're an older patient, that's sufficient. If the patient has higher expectations in terms of their motion, then that is something where they may not be happy with the inability to get behind their back, or their abduction may be limited if they have a varus malunion. But for most older patients, I think they're pretty well tolerated.
Yeah, I guess that, that's kind of what I feel like I've seen. So when you've decided on operative management, let's say you have a patient, geriatric proximal humerus fracture, and you've decided meets criteria to treat operatively, how do you choose techniques like OR? Let's just maybe even break it down: ORIF versus replacement, because obviously, it's different discussion, I think, with the patient, and then also different skill set to some extent, depending on who your surgeon is, and different stuff you got to request. So, yeah, how do you decide? How do you choose, and what goes into decision making?
I think that if you think about it by the New York criteria, so a two-part fracture, displaced two-part fracture that I'm going to operate on in that age population is typically with calcar loss or shaft displacement, typically medial. And that patient, I'm typically doing an ORIF with plain screws. Their likelihood of AVN is relatively low. It's a two-part injury. Sometimes that's the case for me, where I use a fibula to replace or reconstruct the medial calcar if it's deficient. And that's a locking plate and screws. And that's not one that I'm typically having a conversation with the patient about possible arthroplasty, almost regardless of age. When we look into the 3 and the 4 parts, then it becomes a conversation where for almost all of them, I let them know that there is a possibility of an arthroplasty. And so if it's a 3-part fracture with large tuberosity fragment, the greater looks like it's a big piece, and the head is also fairly well preserved, potentially impacted. And I think that I can get an anatomic reduction, and that's one that I will typically try to fix. Sometimes I'll use some cancellous bone graft. I try to avoid fibulas in 3 and 4 parts in case they go onto AVN. But I'll have a reverse available. And then the 4 parts in the kind of elderly group, if we're talking about patients over 70, 75, I'm way more likely to go to a reverse arthroplasty at this point. And I think the data is starting to support that. There was a study in JBJS this past year that looked at that age population, and the reverses functionally did better. They had lower reoperation rates. So I think that if at that age, usually with a 4-part, the bone quality is relatively poor. And I've certainly had patients who have healed in ORIF and done fine. But I think a reverse arthroplasty in that population gives us a little bit more reliable result.
Yeah, those are, I think, some good criteria to decide what to do. I think if people, hopefully everybody's familiar with the New York classification, although, I know there's sometimes discrepancy in what someone might call a 3-part or 4-part. Can I ask you, if that is important, and I think it is to most surgeons, to be able to pin down, how to classify it by New York classification. Are you using plain films? Are you, when are you getting maybe like a CT scan to be able to, or do you feel that allows you to more confidently understand the fracture pattern and making that distinction of how to classify it and then what to do with it?
Yeah, I think for any fracture that anything more than a simple 2-part, where I'm thinking about treating it surgically, I'll get a CAT scan. So if it's what looks like a 3-part on an X-ray or a 4-part on an X-ray, and I'm thinking about surgery, then I'm going to get a CAT scan. The other scenario is that if I'm not really sure how displaced the tuberosity fragment is on the plain film. If the plain films are just not great quality, patient hurts too much to get adequate films, I'm concerned that the tuberosity may be pulled off around the back or more displaced than it appears on the X-ray, then I'll get a CAT scan just to confirm that treating that patient non-operatively is the right move. So, with proximal humerus fractures that I'm treating surgically, I'd say I get a CAT scan probably 80% of the time. And for the non-operative ones, it's less common, maybe 10% or 15% of the ones that I'm just trying to confirm for myself that non-operative treatment is the right move. It's usually the younger patients that I'm on the fence about.
Okay, good to know. Last question. Do you have a couple of quick tips that you've learned that you'd like to share to improve surgical outcomes, either with ORIF or reverse or both?
Yeah, I mean, I think that when you think about ORIF, I think that the number one most important variable in terms of getting a good result is being able to achieve an anatomic reduction. I think that's been shown over and over again in the literature. And so that's easy to say, but hard to do. I mean, I think we all know that these cases are not easy. These are hard, technically complex operations. And so I think when you look at a fracture, you have to be honest with yourself about whether you can get that anatomically reduced. And if you can't, then either you decide that either preoperatively or intraoperatively, then you should do something else. And whether that means send it to somebody else, whether it means do an arthroplasty, you just have to do something else. If you can't get an anatomic reduction, that's sort of where you should stop. And so getting it, my process for doing that is first reducing the head to the shaft, making sure that's anatomic, pinning that in place, and then reducing the tuberosity to the intact segment. And that works well for me. But then it becomes a matter of putting your hardware in the right spot, which I think is a lot easier. I think we understand that getting the calcar screws in plate fixation is critical. And so we've shown that getting that within 12 millimeters of the calcar is important. And so I think if you do those two things, get an anatomic reduction, get your calcar screw and your plate in the proper position, then your chances of having an excellent result are very high. I think we all put suture in the rotator cuff now to augment our fixation. And even though that hasn't been completely supported mechanically, I think most of us feel like that adds something. And so I think if you do those things, not only do you feel more confident that you're going to heal, but that you can start early range of motion, which is also important. I want all of these patients moving by 2 weeks at the latest, because I think stiffness is probably the number one complication after any proximal humerus. And so if we can get them moving early, I think our functional results are the best. That's the ORIF. And then I think the reverse is again about tuberosity. Healing is important. And so again, reducing the tuberosity anatomically is difficult in a reverse too, because there aren't a lot of landmarks. So you have to find a read on the lateral side in order to get that tuberosity back exactly where it was. And then judging your height of your stem can be a challenge for people. And you can't as reliably use some of the markers that are in the literature, the PEC in a reverse. And so, I simply assess how much of the calcar has gone with the head segment and has been removed. And so I'll measure that. And if if the head has no calcar attached to it, then I'll position my stem right where the calcar is. And if the head has calcar attached to it, I'll measure how much calcar is attached to the head. And then I'll cement my stem slightly proud based on that measurement. And that seems to work out pretty well.
Okay, great tips for both. I still use sutures. Does make sense to me. Actually, I did see some data presented at a conference just about a month ago, biomechanical data that I guess is submitted for, I think it's actually accepted for publication, so it might come out. That does, in fact, support and maybe refute some of the recent data we've seen that maybe cuff sutures don't help. So I don't know, maybe that thinking will come back and support that use.
Yeah, I think that's important to come out because, and I don't know how they did that study you're talking about, but some of the issues with prior biomechanical studies are that they're all two-part fractures with a gap model, and so the tuberosities are not typically osteotomized in those models, and so we understand, I think, that the cuff fixation is really to support the tuberosities. And so I'm sure in that study, they did more of a 3-part, maybe a 4-part model.
I can't recall. I'll let you know offline in case that's something you want to pursue with the author. Listen, Dr. Namdari, great stuff talking about geriatric proximal humerus fractures. There was actually, last thing I'll say, there was a recent current concepts review paper in the JBJS about 1 month ago on this topic. If anyone wants to follow up and read about it, or if you want to hear more about this in our live conference, again, next Saturday, June 12th, go to orthoclips.com for the link. And Dr. Namdari will be there with us with our panel of experts. Surena, it's been great. Thank you very much.
Thank you. I look forward to the conference. See you then.
Yep. See you then.